Yes, no, absolutely. So first of all, thank you for giving me an opportunity to do this interview. And one of the first things that I want to highlight relating to artificial intelligence and the work that we do is I certainly think that things like generative AI, artificial intelligence, they're certainly complementary tools and not the only tool that I think we should be using when it comes to the discussion that I think we're about to have today. I think other advanced analytics and other technological advancements together with artificial intelligence methods are the types of things that we should be doing to deliver that most holistic care to our patients. So while most of the work that we do here at Renal Research Institute is really focused on clinical care, we do have a few examples of work that we have done relating to more administrative tasks. And one of those examples, for instance, is using AI-driven tools to streamline some of the transcriptions relating to patient notes. So when patients and physicians or other clinical staffs have communication in the clinic or discussions in the clinic, we can record it and it's automatically transcribed. And not only it's automatically transcribed, we can use large language models to derive some additional insights out of the conversation that the clinicians and the patients may have. So this is certainly one of those use cases on the more administrative side. When it comes to non-administrative areas and more the kind of the bread and butter of Renal Research Institute, which is the clinical side of things, we have a suite of over 30 different algorithms that our team has developed. Most of them machine learning or artificial intelligence like algorithms. They can predict things like when will somebody go to the hospital? When will somebody go to the hospital for fluid-related admissions? When will somebody go to the hospital for infectious admissions? Which in-center patients are best fit for home modalities? When would the patient's fistula mature by using data from Critline and from based on their oxygen saturation and things like this? So again, I think just to reiterate, while there's quite a few different examples of using artificial intelligence, I do view AI as a tool in the toolkit of really trying to provide better care to our patients in the future. Yes, absolutely. So first of all, what is RAG? And RAG is, or retrieval augmented generation. First of all, it's an advanced artificial intelligence approach. It uses both information retrieval together with response generation that is based on very specific answers, evidence-based answers. And so, of course, it's particularly useful for medical education. It is useful in other areas as well. But for example, if you have a clinician in training and they're using these RAG-assisted tools, so it's large language models that are supplemented by additional data, by additional RAG data, you're able to then have questions that are very specific to whatever the issue that we're trying to understand. So for example, if the clinician is trying to understand something relating to hypovolemia in a patient, and then the clinician can actually download additional literature that is specifically focused on hypovolemia. And so you can have a large language model that uses its foundational information, but plus it's augmented by the data and the papers that might have been downloaded related to hypovolemia. And so these answers then that ChatGPT will generate that will be much more specific to hypovolemia as an example. And so that to me is RAG. And again, I think there's many other use cases. And on the administrative side, since we talked about that a little bit earlier, I think another example is if you have a lot of data from human resource organization and you want to have a chatbot that is very specific to the policies of your organization, you're able to then, again, take the data from the specific policies in the HR organization, and then you can have RAG that responds to the questions that are based on the policies that are specific to that organization. Well, again, first of all, I think in my role at Renal Research Institute, certainly safety, transparency, things like bias and accounting for bias are extraordinarily important. And I think it's important for patients, it's important for doctors, it's important for nurses. It's important to have it to be able to gain the trust of our clinicians. So this said, I can also say that some of the most complex systems that we have in healthcare often do lack transparency. And of course, we all know it's called the black box phenomena. And sometimes it is difficult to be able to provide all the complete evidence of how a certain decision was derived. So I will admit that this issue of black box and explainability is not a new problem necessarily with artificial intelligence, that it has existed before. Now, with that in mind, we do have several strategies that we have utilized to be able to address some of these issues, again, relating to transparency, relating to safety, relating to accounting for bias. And so number one is we do, as soon as we start working on any of these models or any of these approaches, one of the first things we try to do is making sure that transparency and safety and bias are thoroughly assessed at the very beginning. What are the possible areas for bias in a given analysis that we may be trying to do? What would be some of the transparency related issues that we need to account for? How will the model actually get used? Where would the clinician need to have some additional information to be able to truly derive at the conclusions of the information that they need to be able to make their clinical decisions? So that usually happens, in our case, that usually happens in the very first stages of model development. We also try to make sure that our artificial intelligence models are combined when we can with more interpretable models. And of course, our team at Renal Research Institute is not just AI experts and machine learning experts, but as I mentioned before, we also have people who have degrees in statistics, but also degrees in mathematical modeling. And so combining these more AI, sometimes black box approaches, together with more interpretable models by using things like deterministic modeling with mathematical modeling helps us in this area a bit as well. And then finally, we are studying what's called human AI collaborative pathways to really try to figure out how can we improve the ergonomics of assisted decision-making in healthcare, where we do have these much more transparent decisions that AI models are generating. Sure. No, absolutely. So number one is I think we are very, very keen on making sure that we involve clinicians, and I mentioned this a little bit before, but we involve them from the very first step of the model development. To us, AI, machine learning, any of these techniques, they're supposed to be supplementary, and they are supplementary to the work that our clinicians are doing. So this is not a substitute for the work that clinicians are doing, but really a supplement. And so with this in mind, of course, to us, making sure that we have that transparency from the very beginning is very important. So demystifying artificial intelligence, where we can show not just its capabilities, but also its limitations. We try to do that education early on, and we help the clinicians understand what it really means and how does it actually work behind the scenes, so that it's a little bit more transparent to the clinicians. And again, as I said, it's demystifying artificial intelligence. We also very often provide very real world examples. How does the prediction that we may get, how does that compare to the clinician opinion? In many of our models, one of the first phases of what we do once the first prototype of the model is developed, the first phase is not to see if the intervention actually worked. The first question really is, what is the agreement between the physician's opinions and what the artificial intelligence model may be telling us? So I think having that at the very early onset is really important, and running that as a pilot for a few months, I think, is typically also very important, because it does buy a little bit more trust in what we're trying to do, and that the clinicians can actually trust the results of the model. So once again, I think involving the clinicians very early on in this process, making sure that it's an approach that we do together in developing these models, is really critical to us.